Do you have any thoughts? People have raised questions about the control arm, and we know from Dan Califf and Kim Chi's data that the ARPI switch or ARSI switch often doesn't give a great benefit. We know, this is a common approach across many, many trials. And I think this data gives us real confidence in those patients who can't get chemo. But what about in the patients who could get chemo, after an ARSI as first-line treatment? Do we think lutetium should supplant chemotherapy as a preferred second line, or what's the role or sequencing of these agents?
There have been many questions regarding the control arm, which excluded taxane chemotherapy. Let me make a couple of comments. First of all, in the real world, the most common secondary manipulation in the context of metastatic CRPC for patients progressing after one ARPI, the most common choice in the real world is a second ARPI. Now, that doesn't mean that it's right. I think that docetaxel would be a viable option. As it turned out in this trial, patients that were thought to be best treated with docetaxel were not randomized on the trial. This trial exclusively had participants who were thought to be good candidates for a second ARPI. That does not mean they were taxane ineligible. It's interesting, if you look at the prospective literature, there actually is no data to show that docetaxel prolongs survival in a prospective randomized trial in this setting. Now, what we do have is something like Triton 3. Now, Triton 3 was in a BRCA1, BRCA2 ATM setting and published in the New England Journal a little bit earlier this year. We saw that in that particular HRR mutated group, that the taxanes looked superior to an ARPI, but it was not done in a formal randomized way. And there we looked at the RPFS, and it was probably somewhere in the 8 to 9 month range. Here we had 12 months, but the populations are different. And I think that's fairly pointed out, that you can't assume that an HRR is going to be like an all-comers population. We do have data from therapy trial performed in Australia, looking at a taxane cabazitaxel in comparison to lutetium. What was found in the therapy trial is that the overall survival was pretty much equivalent, but the adverse events were far fewer in those treated with PSMA lutetium. Could taxanes have been a choice for participants in the PSMAfore trial? Absolutely. What would those have shown? I think it would have been better than an ARPI, but we don't really have comparisons to Pluvicto, the PSMA lutetium in this space. Only in the therapy trial setting do we have a direct taxane to PSMA lutetium comparison. But again, to emphasize, fewer adverse events for the PSMA lutetium.